السلام عليكم حياكم الله جميعا. We are very sorry today because our presentation will be a little bit long. It has a huge number of slides, but unfortunately, this will be the last chance for us to give you something regarding the quality before the Sibahi accreditation. So we all gain work. We can work, but together we win. So working together and working as a team, we can achieve better outcome, sure. So I'm going to talk about a few things which is very important for the quality. So most of our quality items, you'll find it in the ICT. If you'll go to the departments, you'll find pediatrics, and from pediatrics, you can find most of the things related to the quality. So I'm just going to highlight something that's very important for us, like the manuals. Once you press on the manuals, we updated this year pediatric.
Sorry, Dr. Adnan. Dr. Adnan, can you tell us again how to get to there?
From ICT. Is it clear?
So ICT, and then you go to what?
Departments.
Okay, got it. Thank you.
Then pediatrics. Then you'll find most of the things is there regarding the quality. Looks like, I mean, job description, policy, procedures, strategic plan, mission, vision, most of the things there. CBG's manuals, which we have very important manual, pediatric departmental manual, we updated this year. And medical staff by law, it's very important. Please just visit this place here and you can find these manuals just to have an idea about it. So like, sorry. Like a pediatric departmental manual was updated this year. Just you can go through it, what it's contained there, and just to have an idea about it. No need to go in every single detail, but just to have an idea. So today, the pediatric department quality team will talk about some important things in quality. I'm going to talk about MDR in brief. Just the things we need to do it, please. We need at least for the critical patient, at least NICU, PICU minimum, to have weekly MDR for the critical patient at least, starting by that. And we need it to be at the real time MDR, not every subspecialty will come in different time. And it should be documented in the file just to show that the people really that we are doing good MDR. So how to do it in practical? Just we'll go to the ESAHI ad hoc. Then you'll go to all items. From there, you will go to the patient care. From patient care, you'll go to multidisciplinary care plan. Then it should be initiated by the physician, nurse, or any other person cannot initiate the multidisciplinary round. Then you can fill this things, need patient, need isolation or expected discharge date or anything still pending. What's your plan for this patient? If you want to add something later on by any other team, so just go to the form browser, then you can go to the MDR, just right click, modify it, and you can add the things you need to add it from any other team members. So starting by quality about EOVR, we'll start by Dr. Roland.
السلام عليكم صباح الخير everyone. طيب can we go further؟ هحكي إن شاء الله اليوم عن ال OVR. طيب so every time you report an OVR we are a step closer to making our hospital safer. طبعا هذا اللي بيقولوا لنا إياه risk management unit, which is really true. طيب if we go, so what is the EOVR? So it's اختصار ل electronic occurrence variance reporting. Is it important? Yes. Why is it important? لأنه it will highlight the problem, so we will be able to solve it and prevent it from reoccur And so our practice will be safer, and overall our organization work will be improved. So why do we have a very low rate OVR? I think طبعا ما في مكان إنه نطرح أجوبة ونسأل الناس، لكن I think some people they think إنه it's a non-justice culture. حتى لو أنا عملت OVR ما حأخذ حقي ولا ما شيء يتحسن. Some of them think that there is no time, we have a lot of workload. Some of them, they think that it will reflect my relationship, خصوصا juniors, they will think it will it will make a problem as seniors. And simply, ممكن they don't know. Some people, they still, up to now, they don't know. طيب, the name of our pediatric department OVR, بعد يا دكتور عدنان. ولا هي programmed. So the name of our pediatric department OVR handlers, الدكتور لسه عدنان اللي قبله. الدكتور عدنان من ال NICU, الدكتورة ربانة من الجنرال بيدياتريك, والدكتور ماجد من ال PICU. And happy to tell you that we can receive a feedback on your OVR, and you have option to write your name or not. طيب, next. So how to report an OVR? كل السحر بال ICT. So if you go to the ICT, next you will have the toolbar for quality, and then you will click, هيطلع لك OVR new form. So you will click على new form, and then you can initiate your OVR. تمام. قبل ما ناخذ examples في things important I want to tell you. في مثلا icons meaning star red هذا it mean mandatory, must be completed. question mark it's a help if you need help in any question. وهذه السهم اللي تحت it's a drop down list, so you can choose from whatever is there, no need to write it down by yourself. طيب, to start with, the classification of OVR it's a patient related or medication related or staff related, non-staff related, organization or documentation. أمثلة بسيطة, patient مثلا it can be abuse, it can be treatment, communication, implementation of care, etc. Medication like medication error, adverse effect of drug reaction. For staff مثلا it's a communication problem, information. For non-staff it can be abuse or missing something or item. Organization it can be safety مثلا. For documentation for sure طبعا it's information related. طيب, if we want to classify an OVR, if we want to document أو نعمل OVR, بيجيكم مثل هي الصفحة. It's very easy. في red dots you should fill it. حناخد أمثلة عليهم. أول شيء مثلا medication. الكاتيجوري medication error. السب-category we have a problem بالprescription. الانسيدنت مثلا wrong dosage أنا حاطة. medical record number حنختار مثلا file number, and then we will write it down, and then a description of the event. مثلا for example vitamin D dosage given or prescribed for a patient 50,000 international unit instead of 5,000. So the immediate action مثلا the dose corrected to 5,000 and given to the patient and OVR written. غالبا الميديكيشن بيكتبوها الصيدلية, لكن أنا I write it down لأنه هذه كانت a successful story, and we could later on decrease it too much. I'm telling you how doing OVR it will help. طيب, another one مثلا patient related like assessment, image أو lab. subcategory laboratory investigation. incident مثلا sample missing. So the description of the event مثلا CSF sample sent to the patient on day so and so by so and so, but after a contact with the lab the specimen was missed, so the immediate action the extra sample was sent and OVR was written. طيب, example ثاني staff related مثلا category communication أو consent, subcategory communication, incident مثلا communication failure outside the immediate team. So description on my own call, date so and so and time. So I contacted Dr. X from specialty X 3 times, but with no response. So the immediate action, the senior on-call Dr. X was contacted and the plan sent for the patient and carried out and the OBR was written. تمام, اللي وراها. So بس تنزل على الصفحة لتحت من ضمن كل OVR في هي الخيارات. Was any people affected? Yes or no. So it's important to write it. Do you require a progress update on your incident? You can choose yes or no. بعدين the reporter department, pediatric department. بعدين الجوب ما مكتوب مثلا is it a consultant, is it a resident, is it so and so, مجرد physician أو nurse أو pharmacist. So it's really quite safe. ما حدا حيعرف مين هذا الphysician اللي كتبه. ممكن الconsultant, ممكن resident, ممكن الintern, ممكن student, and so on. So it's really safe to write it down. It will not affect anything. تمام. And then at the end حيطلع لك incident number INS بالأخير. If you want to have a feedback طبعا you will write submit. If you want to have a feedback ممكن تحفظ بالincident number and you will check it and trace it out. Thank you.
Assalamu alaikum rahmatullah. Good morning, everyone. In the coming few slides, I will talk about things related to the ethics and the organization chart and chain of command. So if we talk about the organization chart, طبعا in the department, the organization chart is usually updated when the pediatric manual is updated, and this is usually done every 3 years, and it was due update in 2020, and it was updated. طبعا probably the majority of you knows that we have about 15 subspecialty in our department, led by head units, and we have also committees. In the committees, we have administrative committees, clinical committees, and academic committees as well. We have, of course, the Department of Pediatrics is led by Dr. Khalid Al Hassan. He's the chairman, and he has 2 deputies: the deputy for administrative issues, Dr. Fahd Bashiri, and the deputy for clinical issues, Dr. Roland Basrawi. And next slide, please, Dr. Adnan. The chairman of pediatric report to the medical director or his deputy for medical services. Medical director is Dr. Sultan Al-Dosari, and the deputy is Dr. Nasr Al-Khamis. And the medical director reporting to the CMO, and the CMO, who's Dr. Prof. Fawz Al-Jasser, will report to the CEO, Prof. Ahmed Al-Harsi. Next slide, please. Okay. Again, I will stress on what Dr. Adnan and Dr. Roland said, that the ICT website that is usually opened within the hospital, it includes almost everything that the clinician needs to know about the medical city and its regulations and the different services in the medical city from this website. It is an icon. You will find it in every desktop. And once you click it, you enter to this website, to this page. Here under the administration, you will have the medical staff bylaw, which is very important for every physician to go over it. The points that is covered in the medical staff bylaws include the staff categorization and responsibilities, how the staff are appointed, the privileging guideline, the development required from the staff, and how the staff are evaluated, the medical staff committees in the medical city, the standard of patient care, code of ethics and conduct, the investigation and corrective actions, and the management of transfer and clinical coverage. Next, please. The second important document under the administration is the KSUMC Leadership Manual. Still, the medical bylaw, it is updated this year, 2020, and leadership manual, I think it is also due update. The copy that is there is 2017. It should be updated, I think, this year. It is updated every 3 years. The leadership manual, it covers 2 parts, administrative and ethics. In the administrative are things related to the leadership structure, the standards of patient services, the plan of provision of patient care in the medical city, the culture of safety and equality in the medical city, disruptive and inappropriate behavior, the dress code acceptable in the medical city, information management plan, the confidentiality, release of patients' information, and to the new media. Ethics, it will also cover the research conduction guideline, the sexual harassment, and the issue of conflict of interest, and issues related to end of life and how to care of dying patients. Next, please. Policies and procedures. The policies and procedures in the medical city are of 3 types almost. The first one is the medical citywide, that is, and also the hospital-wide, which is applicable to KQH, and the department, which is usually done by at the level of department. However, policies that belong to the department can be applied also to other departments. For example, the blood transfusion policies that is and all policies related to blood transfusion, it is applied to the whole hospital, but it is made by the blood bank department. Where to find the policy and procedure? Again, you will find it in the in ICT. Dr. Adnan, if you go to the previous slide, please. And in the ICT, either you go to the department, and in the department you go to the pediatric department, you will find the policies and procedure related to our pediatric department, or you go to the Department of Standard and Performance, also under the departments, or you will navigate it from the left side in the main web page of the ICT. Next, please. Next, please. We have a clinical ethics committee in the medical city, and this is the ethics framework they are following. So once the physician faced by an ethical issue, he needs to report it to the ethics office or the clinical ethics committee, and this is their extension 89847. And the clinical ethics committee, they will try to solve the problem. If they solve the problem, well and good. If it is not solved, then the things will be escalated to the medical director. Then from there, if the medical director was able to solve it, well and good. If not, then things will go to the chief medical officer, who usually will it will be solved at that level. An example of dilemmas that can be referred to the ethical committees, like the do not resuscitate process and order, withholding life-sustaining treatment, nutrition, hydration, patient refusal of services, the patient caregiver confidentiality, admission, discharge considerations, pregnancy termination, relationship, teamwork and communication, respect of patient autonomy, veracity and disclosure, confidentiality and privacy, and conflict of interest. Thank you so much.
Good morning. So just in brief, I will talk about some basic terminology related to medication safety. Actually, those basic terminologies, all of us should be familiar with. As my colleagues mentioned, everything will be in the ICT. So when you just the previous slide, Dr. Adnan. So when you go to ICT, also go to departments, but select the pharmacy. Under pharmacy, you will find medication safety. All resources will be under this icon. So I will talk first about the near miss. The near miss means any event that could have resulted in unwanted consequences, but did not, because either by chance or through timely intervention, the event did not reach the patient. So near miss, if left undetected, it will lead to patient harm. So usually near miss needs also to be reported, just to trigger people about it. So for example, if, and this is a real example, one patient potassium was high, so started on a chelating agent, calcium resonium. After 3 days, the same physician reordered calcium resonium again, but the pharmacy, when he checked the potassium level, he found it dropped from above 6 to 2.8. So he notified immediately the physician, and the physician held the order. So this has, it's called near miss because it did not reach the patient, but you should report it just to prevent future events. Next. Lookalike, sound-alike medications, usually we call it LASA. All of us should know about those medications because it's considered very risky medications if used in errors. So it includes medications that are visually similar in physical appearance or packaging, or for the sound-alike, the medications that have spelling similarities or similar phonetics. There are many strategies just to reduce medications error from those medications. Usually, whenever you are stocking those medications, whether in the ward as ward stock items or in the pharmacy, you have to segregate them. For the sound-alike medications, we have lists in the ICT of all of those items, and usually this list updated according to the medications available in our formulary. So when you, as I mentioned, when you stock them, segregate them. Second thing, you should label them with a LASA label and put or use a tall-man letter. For the lookalike medications, also you should separate them. And usually we will try with the manufacturer just to change the packaging to avoid errors, or change the company. So bring the lookalike medications from different companies to avoid confusion. Next. For the high alert medications, those among the very harmful medications if used in error. So it refers to drugs that bear a high risk of causing significant patient harm. And whenever error happens from medications, usually it will result in patient harm. But from high alert medications, the outcome could be devastating for the patient. So we have a list of high alert medications in the ICT. All of us, from prescriber to pharmacists who will dispense the medication, to the nurses who will administer medication, should be familiar with the high alert medications, because a small error with those medications could result in significant patient harm, sometimes may lead to patient death. So we have a list of those medications on the ICT as well. Many strategies used to reduce the errors from those medications, including first, to just inform or educate people about those high alert medications. Whenever you order in the eSahi any high alert medications, usually the medications next to it, there is alarm that this is a high alert medication. Second thing, regarding prescribing, dispensing, and administration, we encourage independent double checking just to avoid errors with those medications. Follow the guidelines regarding how to give, how to administer, how to dose those medications. So be extra cautious with those medications. Common examples are the heparin, all formulations of insulin, concentrated electrolytes. Usually the concentrated electrolytes should not be stocked at all in the units, except for very few items in case of emergency. And those should be diluted before giving to the patients, and you should follow instruction of administration. Parenteral nutrition also among the high alert medications, and many other medications. Next. For the adverse drug event, I'm talking mainly about the ADRs, or adverse drug reaction. Usually, people are confused between the ADRs and medication errors. Usually, the medication errors, there is some factor that you commit a mistake, then a medication error will happen. But usually with the ADR, the difference that you will use the medication in the right way, right dose, either therapeutic or prophylactic dose, then the ADR will happen. Usually the ADR will come in form if the patient, for example, have AKI after using a nephrotoxic medication. This is called ADR, although you gave him the right dose. Second thing, if you, for example, gave a patient heparin, then he developed thrombocytopenia. If you gave any medication that the patient developed immune-related reaction, all of these are considered ADR. You cannot prevent them from happening sometimes, even if you follow all the right strategies. Whenever ADR happen, you have to report it immediately. Before we have the hard copies, we should not use them anymore. This is not the way of documentation. Just use the OVR system, as Dr. Roland elaborated on this before. Just log into the OVR and put the description of the ADR event. Next. Finally, just I will mention the whenever you need drug reference, we agreed all to have a unified drug reference for the pediatrics. We have here in the hospital the Lexicomp. We have it in all nurse stations, in all units as hard copies, handbooks. And also we have the online version of it. You can access it just from it's intranet, not from outside the hospital. From inside the hospital, you can go to any PC, then just, and it has to have, of course, internet connection. Just type Lexicomp and immediately it will open. Type the medication you want and go to the whatever you want, doses, adverse reaction, or anything. Also, you can access it from iCity. There is an icon in the iCity under pharmacy department for LexiCamp. Also, you can access it from eSahi. When you go to the power chart, go to the icons in the top of the first window. You will find also LexiCamp. It will take you immediately to the application. Also, if you want to download this LexiCamp on your mobile, just contact the Drug Information Center, and they will give you the instruction on how to download and the password. Usually, you can use it offline, the mobile version. We have another reference, just in case you need another reference, a backup reference for together with Lexi. You can use the Harriet Lane. All medications related information will be found in those two references. Next. Thank you. Thank you.
Hello, Assalamu alaikum all. Today I'm going to present the tools about infection control and hand hygiene. As we all know, infection control and hand hygiene measures are very important for care of our patients, for ourselves, for our institute as well. So we're going to take about the 5 moments for hand hygiene. We should all of us know about when should we do the hand hygiene. First one, before touching the patient. The second moment, before cleaning or aseptic procedures. The third one, after body fluid exposure. The fourth one, after touching a patient. The fifth, after touching patient surroundings. So these 5 moments, we should do the hand hygiene. How to do hand hygiene? We have two ways, either to do the hand rub or the hand wash. And these are the ways to do the hand rub and hand hygiene and hand wash. Next, Doctor. We have different types of precautions. All of us know about the contact precautions, droplet precautions, and airborne precautions. But how about the standard precautions? I think not all of us know about the measures of the standard precautions. We will remove the gowns, we will remove the N95, we will remove the mask. But what comes under standard precautions? Proper hand hygiene, the gown, the mask, the face protection, the gloves, safe injection practice, patient care equipment and devices, environmental control, textile and laundry, patient placement and transportation, worker safety, respiratory hygiene, cough etiquette, infection control practices for lumbar puncture. All these procedures comes under standard precautions. Next. So we'll come to the PPE, personal protective equipment. How to don, how to doff. All of us should be aware of the steps of donning and doffing of the PPE. Donning, start with proper hand hygiene, gowns, respiratory care or the mask, goggles, and gloves. Last step is the gloves. On the other side, doffing, we will start with the gloves. Remove your gloves, then goggles, then the gowns, then the mask, then do the hand hygiene. But if you are putting on N95, you should remove the N95 inside the room before you go up. Segregation of wastes according to its color code. Where should we dispense the wastes? We should be aware of the colors of the bags we are segregating the waste, the black, the yellow, the red, and the sharp container. Sharp containers for the waste, for the sharp contents, it should be half full. Within 1 week, we should discard. Even if it's not half full, we should be discarded. How about the red bags for the placenta, body parts, human fetus, as in ICU? This is the most common one, in the yellow one, with the possible healthcare risk waste, gauze, gloves, our gowns, possibly contaminated things. The black one for non-infectious or non-risk waste, healthcare non-risk waste, papers, packaging materials, cups, plates, utensils. Thank you all.
Assalamu alaikum. Good morning, all. I'm going to talk about an important subject, which is patient identification. It really sounds simple, but it's very important. If you can go to next sector. So we're going to talk about why, how, when, and what are special circumstances that's lead. I know this is a very simple and intuitive object that you want to identify your patient before doing anything. But yet we need to emphasize a proper way of identifying the patient, especially around medical interventions and procedure. So if you can go to next, Dr. Adnan. So we want to identify the correct patient to the correct intervention, and that should be happening prior an intervention. And intervention doesn't necessarily means procedure. It means, for example, doing imaging, doing blood withdrawal for test, or doing an LP, or even if you look at X-ray for your patient, you need to know how to from the imaging itself. Because we deal with a lot of patients with similar complaints, similar age, maybe similar names, then we need to be careful. So again, we will find we have a policy and procedure about this patient identification. It's hospital-wide, so you will find it around in the policy and procedure for the hospital, and click on the search function and look for patient identification, you will find it. So first thing I want to transmit is, please do not use location of the patient as an identifier. Don't say the patient in word 12 bid 2. Don't use that as an identifier for your patient. Why? Because patients move. We know that sometimes patients change the room for infection control reasons, or any other reason that the patient might change the room or move the room, or he might be discharged and someone else admitted in the same room. So please don't use the patient location as an identifier. So prior to intervention procedures, you need to have two identifiers for the patient full name, medical record number, or date of birth. So any two of these will be considered as an identifier. So if you can go to next slide now. And must be done before, but not limited to this. But for example, administration of medication, transfusion of blood, taking blood sample, doing procedures, transferring from unit to another unit, even if giving a diet tray. So these are some examples of when to identify the patient and two identifiers. Of course, you can ask the patient himself. If you can go back, just ask the patient your name, your Mr. Flan, your so that's an identifier, and looking at his bracelet as well as an identifier. I'm not going to go into details on how to do it. You can read that in the policy itself. It's pretty long. What's special to beads is the mother and the newborn identifier. So the mother and newborn identifier wristband should be fixed after the mother confirmed the identity of the child of the newborn, and two identification band should be attached to the baby, one in the wrist, one in the ankle, and must include all these information. And even before transferring the patient from the delivery room to the NICU, he must have his band to identify. So this is a very special circumstance. It's a difficult one because the child is just born, and there have been some incidents of either mixing or incident of abduction. So this is why this is very sensitive, very important. One last thing about patient identifier, that you identify by the name of the mother. So baby off and followed by the mother name. And thank you all for your attention.
Assalamu alaikum. Good morning, everybody. I will talk today about the handoff or handover, talking about the structure evidence-based handover practice in patients is a standard care that must be performed by the healthcare professionals involved in patient admitted to the pediatric care areas under most responsible person in Department of Pediatric. Information of all patients admitted to the pediatric care area under MRB and Department of Pediatrics must be communicated between the responsible passing and receiving, and we refer to the passing, the one who will endorse, and receiving, who will take over the endorsement. So responsible of passing and receiving healthcare professional at time when there is a permanent or temporary transfer of clinical responsibility. Next, please. Okay, all passing healthcare professionals must be prepared to pass written and verbal patient information by the time their corresponding receiving healthcare professionals are scheduled to take over their clinical responsibility. Should be protected time for handover, so no other schedule which conflict that may interfere with handover time. And it is the responsibility of team leader, either is the nurse in charge, fellow on service, or the senior resident in CTU. They are responsible for coordination and appropriate delegation of handover within their respective team to assure both written and verbal handover using SPAR or IBAS. And what we are using in our ISAHI system is the IBAS structure. Should be complete at time. The handover of all patients must be completed in no more than 1 hour and must be completed by the start of the shift of receiving healthcare professionals. MRB must be readily accessible, either by their physical presence or over phone during the time of handover to resolve any identified barriers, uncertainties, or conflict by the passing or receiving healthcare professionals. As part of their role as medical educator, MRB are encouraged to assess the performance of healthcare professionals under training while performing patient handover and providing feedback, and complete the end of rotation evaluation of trainees' skill areas pertaining to leadership and communication. All healthcare professionals are required to report improper or incomplete patient handover to the Pediatric Quality Improvement Committee through the OVR system. The role of pediatric QI teams to take the responsibility of maintaining and optimizing patient handover by SPAR or IBAS, whatever tool we are using, through regularly reviewing OVR reports related to the patient handover, placing and evaluating intervention that improve the quality of handover process and address reported issue, monitoring and maintaining the adherence of healthcare professionals to the practice of patient handover by SPAR or IBAS structure by using suggested KPIs, reviewing and revising the pediatric handover policy and procedure every 2 years or more frequently if needed. Then we will present briefly how we do it in our ISAHI. When you open your account in ISAHI, the interface you will find in the top the patient handoff. If you click it, you will go to the patient list that you already made in your account. It will show all the patient area that you initiated in your account. Then the patient, if you choose the area, the patient list will come to you. Then you can go and choose your patient. Then the page of IBAS will appear. You will find the IBAS tool, then clinical data and the care team. If we go the IBAS tool or structure, first thing you have to identify your the patient illness severity, and IBAS is the abbreviation of illness severity, patient summary, action list, situation awareness, and planning. And the other thing. Anyway, after you finish you putting your data, if you go to the clinical data, you will find the labs. You can review it in the last 24 or 48 hours. Then you will have the medication the patient on. If you go to the care team list, you will find mostly the nurses who's taking care of this patient. If you enter your information or data about this patient, don't forget to save this information. And at the end, it will appear in this way that you completed your handoff. and it will show the situation of the your patient in different color, if it's stable or watchable, or he's ill in different color according to his condition. Thank you.
Good morning, everyone. I will talk briefly about the medication reconciliation. Next. Medication reconciliation is designed to avoid the most common medication errors. Medication reconciliation involves a three-step process. The first one is verification, which is collecting an accurate medication history. Second is clarification, ensuring that the medications and the doses are appropriate. The third is reconciliation, which is documenting every single change and making sure it squares with all other medication information. Next, please. Details regarding the steps of this medication reconciliation, we can briefly say the first step, obtaining the possible medication history. The second step is confirming the accuracy of that history by verifying the one or more resources. Third one is comparing these possible medication history with the prescribed medicine to resolve the discrepancy with the prescriber and the document changes. Finally, we have to supply accurate medicine information. Next. This is a practical training. After opening to the eSahi access and open the correct encounter of the patient's file, we have to go to the order, and then we go to the document medication by the history. Next. It will appear three options we have. The first one, we can add, if we are pressing to the add, we can add manually. And the second one, if there is using the last compliance. If we press it, it will be retrieve the last compliance. The third one, if there is no medication history, we can click on it. Then we press on the document history. Next. And we have to make sure that on the reconciliation status, it will appear check in front of the medication history. Then second, we have to go from the reconciliation, we will select admission. Next. On the admission side, we can see here, we can add the medication and press on the sign. Next. And we have to make sure there is now second arrow in front of the admission. So already reconciliation status, checked by medication history and admission. Then for the discharge, if we are applying to discharge the patient, we have to select from reconciliation, discharge. Next. The same as we are doing on admission, we add this medication and we have to stop, for example, the inpatient's order, or and we can add new medication from the press add, and finally to submit by pressing on the sign. And we have to see the reconciliation status checked 3 times with the tick on medical history, medicine history, and admission and discharge. That's it. And thank you for listening.
Assalamu alaikum. Good morning, everybody. For the coming few moments, I will talk about the clinical consultation policy and procedures. As you know, consultation is one of the most commonly applied on a daily basis practice, actually. And for doing it with a high quality practice, we have a policy and procedure for it. It's a hospital-wide policy, and it's have been there since a long time. Recently, updated to be aligned with the eSahi, and it's titled as Clinical Consultation Policy and Procedure, hospital-wide CPP-025. You can access this policy and procedure from the ICT, again, as my colleague previously explained, department, pediatric, then you find policy procedure on the left column. You just go for the medical city and hospital-wide policy procedures, and you will find it the second on the list. or from the ICT homepage. The left side, there is the main surface. Again, you will find an item called policy procedures. And from there, you can type, there is a search box, you will type the title of any policy procedure you want to access. You will type, in this case, clinical consultation. This policy is applied to all the healthcare provider in the medical city, and it states that who should initiate the consultations, usually the attending physician. They're referring to attending physician as the physician who's providing the care for the patient during this specific episode or event. So not necessarily the primary physician in general, but during this admission or this clinic visit. And once consultation is initiated, it shouldn't be refused by the consulted physician or ancillary healthcare provider. And again, it's responsibility of the attending physician to practice the proper and timely consultations for the patient. Next, please. The procedure will start by initiating the consultations and writing the consult order. We'll go through it and how to document it, but it's very important, the two underlined points, which was usually missed during the survey for the documentations, the priority types and the reason of consultation. So please, reason of consultation should be written clearly and correctly. And this is the responsibility of the attending team to write it. And should be signed, of course, by the one who ordered it. Next, please. And for the priority or the type of consultations, the time response, we can call it, routine consultation should be completed within 24 hours from the initiation of consultation, and ideally during the same working day, unless the team can be delayed. For the ancillary consultation, which is the other health care providers, can be done within 24 hours. Urgent consultation within 8 hours. And for the stat consultation should be within 20 minutes. And this should be accompanied by verbal communication and the stats. Next, please. If the consultation is coming from the emergency department, the response time is different. If it is like a code announcement and you are a part of the one of the code teams, you have to respond as soon as possible and in accordance with the code policy. And if you are in-house on call, the response should be not less than resident level and within 20 minutes from the notifications. And for the home on call, it can be within 60 minutes from the notifications. And for the emergency, if it is like an urgent intervention needed, they should make it by consultant or senior registrar and assist by phone consultation. Next. So who should communicate with the consultation team? For inpatient all, it should be physician to physician verbal communications. The policy didn't state the level of this physician, so any member of the team who should know about his patient and of course have the basic communication skill can proceed for the consultations. The follow-up of this consultation can be done by even non-physician, like the nurse. And the consultation, of course, the response should be from the consultant on charge during the working hours and the on-call team after working hour. Next, please. The consulted physician is responsible for, after seeing the patient, providing and filling the consultation note. Again, we'll talk about it in the coming slide, like it's very important and to fill it. Reason of consultation should be written clearly. And the first few parts, as you know, the team most of the time know it, but what they really need, the assessment plan and opinion and recommendation, which have been noticed during the survey and during the practice. This is most of the time missed or not written clearly. Oh, it's been unfair for even the consulted team itself. Yeah, they are coming discussing the case among them, but the one who's documented is not writing the opinion or the plan and recommendation very clearly. So this is a must, and it has been found to be missed in most of the consultation. The name, of course, electronically, the one who is documented will have the name, but if he is not the consultant, he should mention the name of the consultant during his documentation. Next, please. This is the most, I mean, what about the consultation? But to know about it, we have a monitoring KPI for it, which is the time for order consultation and the consultation done as per priority. I mean, according to the priority, it's done within time or no. And of course, if there is any medical legal issue arised, the consultation documentation will be revised fully for even decision. Next, please. Here, just to see, document how to start the initiating team or the consulted attending team, just order, and then you just type for the new order, add order, new beat consult, and you will have a drop list of all the specialty you might consult as beat consult. Next, and then the consultation documentation window will appear. Here, as we said, the time and name will appear electronically. You have to write clinical summary about the patient in the special instruction. Here is the priority of the consultation, and here is the reason for consultation, which again should be written very clearly and fully. Next, please. For the consulted team, once you start seeing the patient, you just go for the consultation order itself and right-click and just click complete. So that means you completed it, because this is the time it will be assessed and measured, the time from consultation to complete. And after seeing the patient, assessing the patient, you will go to write, document your notes. Next, please. This is the way, again, documentation. You will add the new documentations. In the documentation type, you will find the pediatric consultation, and the template you will write on is the consultation note template. Next, please. This is the template again. All the things which has been mentioned there, it will appear here. And for assessment plan, electronically, it will appear if there is like a problem list by the team, but you can delete all this by this small X mark, and you write your opinion if you don't want to write it by problem list pattern. Again, as you can see, all this is written in the consultation, I mean. So all this is written in policy based on the ESAHI. So please apply it when you do your consultation. And thank you.
Assalamu alaikum. I'm going to present a quick overview of general safety. First of all is our emergency code. What is emergency code? Our coded message often announced over a public address system of hospital to alert staff to various classes of on-site emergencies. This color coded indicator include unique prescribing criteria for how staff members should respond to a particular situation, ranging from fire incident to cardiac arrest. Next, please, Doctor. We have two types of emergency code: non-medical emergency code and medical emergency code. Both this code, we have hotline of them, 953. Non-medical emergency code included yellow code, means external disaster, code black bomb threat, code fire, code red fire, code orange spill management, both for chemical and radiation, code brown utility failure, code white competitive abuse, code green for emergency department overcrowded, code silver active shooter, and code pink means child abduction, code gray severe weather, and code MB missing patient, code downtime for ESAHI failure. For medical emergency code, we have 4 codes. Code blue means adult CPR, code purple child CPR, code RRT rapid response team, and code trauma. Next, Dr. Adnan. Be sure you have this card with you, please. Next. I'm not said why emergency code are important. It's important to convey essential information quick with minimal misunderstanding to staff to prevent stress and panic among patient, visitor, and staff. I will talk about fire and safety. There is things we have to know. You have to know the fire extinguisher in your area, how many extinguishers, and the location of it. Location of fire alarm and fire exit, evacuation, and assembly point. Next. This is schedule show the pediatric unit exit. In each unit, we have 3 exits. Secure exit in your work area. Fire exit should be not locked, not obstructed, and panic harmed, and it should be fire resistant and clearly marked with illuminated exit sign. Okay, next, Dr. Adnan. What is the evacuation? Evacuation is a process of removing occupant from danger to safe area. This plan posted in all hallways in hospital. And during evacuation, we will follow, next, Dr. Adnan. We will follow REST method, REST meaning rescue, R rescue, A alarm, C contain, and E extinguish. And all of us, we do the training for how to use extinguisher, follow bus steps, pull, aim, squeeze, and sweep. Assembly point. Assembly point, it is a place where people to meet or gather in an emergency. All this point is out of a hospital building. You have to check the nearest point to your workplace, and there is 7 assembly points in hospital. The main evacuation center is at the helipad. Next, Dr. Ab. The last thing I will talk about shut-off medical gases. In case of fire or related emergency, make sure no patient connected to oxygen, and you make sure you know the location of your unit in your unit of shut-off valve. The key is available with the charge nurse or head nurse, which they are responsible for the closure of shut-off valve. Thank you.
Dr. Yasser?
So
we might need maybe another 10 minutes, sorry, because we don't have chance again to present the remaining. So we are going to take maybe 10 minutes extra just to finish everything. Thank you very much. Dr. Yasser.
Okay, I would like to brief you about the evidence-based clinical practice guidelines, or as they are commonly known as CPDs. Actually, CPDs is one of the prides of the pediatric department and of the medical city in general. I can still remember in 2014 during one of the Accreditation Canada final reports, there was Dr. Ulfat Sheikh. She's a pediatrician and a quality professional from UC Davis in USA. She announced in front of everyone that the pediatrics department is one of the early adopters of clinical practice guidelines. Next, please. We like to present the CPGs as a program because it's a collaboration between different bodies. Next. So we have something called the CPG Steering Committee. This is on the level of the medical city, and we have in each department a CPG departmental committee. The pediatrics one is one of the oldest ones and the most experienced. Historically, used to be led by Professor Sarrar and then Dr. Tahani. And currently, Dr. Reem Al-Khalifa is the chairman of the CPG departmental committee. Each CPG project usually has a CPG adaptation group, and we usually have the support of all of the heads of units and chairmen of departmental, the top leadership. Next. The methodology of production of our CPGs is not like just copy paste or a narrative review of guidelines. We use one of the formal methodologies of adaptation of guidelines. It is called KSU Modified Adapt. It is published, and it is a good example of one of the official and formal methods of adaptation of guidelines. Next. How to access the pediatric CPGs. If you go to the iCity and click on departments and click on the pediatric department, we have a special page for the department. Next. You can see the menu on the left side. If you go to the clinical practice guidelines, it will redirect you to the page of the CPGs. Once you open this page, you'll find the page is divided into two parts. We have now 9 official CPGs in the pediatric department and 3 CPGs initiated by other departments, but they're applicable in the pediatrics. All of these are we call it the full documents for CPGs. These are PDFs that include an extensive document that describes the whole process of adaptation and all of the components of the CPG. Next. Just to summarize the overall process of adaptation of guidelines, very briefly, we formulate a team, we choose a high priority health topic, we write some health questions, which we want answers, we want the guideline to answer. We identify eligibility criteria for the appropriate CPGs, and then we search for them, we find them, and we conduct a quality assessment of these eligible CPGs. At the end, we will come to selecting one or more of these source CPGs. We draft the guideline and send it out for something called external review. And including in the package of the CPG, we have something called implementation tools, which are actually practical tools that would help the physician to use the CPG. Next. So right now we have 9 officially approved CPGs for the pediatric department. Sepsis was initiated by the PICU, diabetic ketoacidosis by the endocrinology, acute asthma and bronchiolitis by the pulmonology in collaboration with general pediatrics, fever of unknown source, ID in collaboration with the general, neonatal jaundice from the NICU, status epilepticus from neurology, sedation and allergies again from the PICU, and recently the ADHD. 2 nice things I would like to highlight. No, sorry, Dr. Adnan, can I go back? 2 nice things I would like to highlight about all of the CPGs of pediatrics. All of them have been endorsed by the Saudi Pediatric Association, and thanks for Dr. Abdullah for this. 2 of the CPGs have been again endorsed by more than one society. The status epilepticus was endorsed by the Saudi Pediatric Association, Saudi Pediatric Neurology Society, the Saudi Epilepsy Society, and the Gulf League Against Epilepsy. The last one, this is the most recent. This is actually the first national CPG for ADHD using our methodology, the KSU Modified Adapt, and it has been endorsed by 5 different Saudi professional societies. Next. These are other CPGs that were adapted by other departments but are still applicable to the context of the pediatric practice. IV immunoglobulins was initiated by the Oncology Center, but with heavy contribution from the pediatrics. Pediatric neonatal parenteral nutrition, initiated by the Pharmacy Services Department, but you can see from the title, it's the pediatric one. Acute bacterial rhinosinusitis, it was done by the ENT, but it has a whole section for pediatric bacterial rhinosinusitis. Next. A famous comment we get from our CPGs that it's a long document, but the thing is, all of these components or the table of contents of our CPGs were based on high quality standards of CPGs. I mean, high quality guideline must document all of these sections. But for clinicians' use, practically, you need to only look into these red titles. So once you open one of our CPGs, you will look in order to the scope and purpose, which will give you the health questions, or I mean, just to decide whether this guideline is suitable for your specialty or your patient or not. If it is, then you'll move to the recommendations, which is the meat of the CPG. And in addition to the section about implementation tools, which are actual practical tools like algorithms, KPIs, checklists, and finally, I mean, for further evidence or background, there's a section for references if you are interested. Next. So again, we have two forms of the CPGs. You have the PDF full document, and you have these are actually one of the implementation tools. We call them the CPG Power Plans. Power Plans is the sterner name of something we call CPE with order set, or computerized physician order entry with order set. More senior staff maybe will recall the old doctor order form, which used to be in paper. So simply it is computerized now, and it's called the ISAHI. There is two ways to order the CPDs through these power plans. If you open the power chart in ISAHI, either you'll go to a folder called power plans, or you'll go to the pediatrics folder. You can order it as it is, or you can modify if you want to add additional orders, lab investigations, medications, whatever. And actually, this is the only way you can document CPGs in ISAHI or in the electronic medical record. Because unfortunately, one of the challenges we received from the last ISAHI survey, although CPGs was one of the success of the medical city, they commented that we are not documenting and not implementing our CPGs. One of the solutions that has been discussed, and maybe we would like to hear your feedback later, like an alternative, temporary alternative for using the CPG power plans in ISAHI is simply to document in the progress notes, although we don't encourage the free text documentation, but you can still document in the free text that this is according to this specific CPG. Just try to note that this is according to the CPG and write the title of the CPG or the reference number or anything that will link that you have reviewed or read or are aware of the CSUMC relevant CPG. And there's an educational a short video about CPGs and how to order them on ISAHI. We can share with you later, inshallah. Next. This is the Dr. Adnan, just 1 second. Can you go back? You can see this icon on the lower left side of the slide. We call it the pizza icon. This is actually the icon of the power plan, because some of our colleagues are confused and they say they cannot find the power plans in the orders. Once you type the name of the disease, you'll get a list of orders. One of them will have this icon. Once you see this icon, this is a power plan or an order set, which means it's a collection of all relevant orders under one diagnosis. Next. So again, this is a list of the CPGs that have been built already as power plans. You can see most of them are built. A previous audit we have conducted on the usability of the power plans in the medical city. Actually, we issued a report for both. Actually, one of the two best power plans built on the ISAHI, one of the most mature one actually, was the DK and the status epilepticus, but the usability was so low. Although there was continuous awareness sessions and training and response to questions or troubleshooting, the DK usability was only 29%, and the status epilepticus was only 5%. So we would like to ask your support to use these CPG power plans.
Okay, assalamu alaikum. I'm going to talk briefly about the blood transfusion process and standards. So a blood transfusion policy is approved by the Blood Utilization Committee. Can you go to the next slide, please? The next, please, Dr. Adnan. So blood transfusion process includes 3 steps, things to do before transfusion and things to do during and after transfusion. So what you have to do before is to complete the request forms for administering the blood to the patients, to make sure that identification and confirming the patient ID, take the consent from the patient or their family, and send a sample for cross-matching. Next. During and after blood transfusion, the patient should be under close monitoring. Assessment for the signs and symptoms of transfusion reaction should be done by the physician in every shift. Assessment by the nurse hourly for any clinical and vital instabilities. Next. If you are suspecting transfusion reaction during the blood administration, the safest practice is to stop the transfusion and keep the intravenous line open with normal saline. The next step is to check for the information in the blood unit label and the patient's identification to ensure that the right blood unit was administered to the right patient. The other thing is it's important to keep the residual content of the blood component and retain it to the blood bank for further investigation, and to send a new fresh sample from the patient for further investigation also, and any investigation for any suspected transfusion reaction should be planned as per the physician assessment for the signs and symptoms. But a general rule, when any unexpected symptoms or signs occurs during or shortly after the transfusion of a blood component, a transfusion reaction must be considered as a precipitating event until confirmed otherwise. Next. So some of the acute life-threatening reactions include acute and delayed hemolytic transfusion reaction, transfusion-transmitted bacterial infection, anaphylaxis, transfusion-related acute lung injury, and transfusion-associated circulatory overload. Next. Classification of the transfusion reactions based on the immune and non-immune causes, and some of them happen during the first 24 hours and some of them happen late after 24 hours. I'm not going through each one of you, but it's important that you know the signs and symptoms for each to be able to recognize any symptoms and manage accordingly. Next. Next, please. Minor transfusion reaction symptoms, these include the hives and rash that cover less than 25% of the body, and there are no other symptoms. Or if there's increase in temperature by 1 over the baseline or higher than 38, but also there's no other symptoms. Next, so the first step is to be taken is to stop the transfusion and make sure that you give the right blood to the right patient. You have to notify the physician and notify the blood bank. If there's any additional serious symptoms, do not restart the transfusion. And if there's no additional symptoms and you make sure that the right blood was given to the right patient, you can restart it and cautiously monitoring the patient. Next. This is some of the algorithms that can help you in managing and suspecting the signs and symptoms in each patient and what could be the transfusion reaction. And based on that, you can manage according to that and consulting PICU if needed. Next. This is another algorithm also mentioning the process if any transfusion reaction happens. So the most important thing is to stop the transfusion immediately and keep the IV line open with the normal saline. To contact the physician and authorized practitioner for medical assessment. Check for the vital signs at least every 15 minutes until the patient is stable. Check the labels, tags, treatment order forms, and the patient's identification band to determine if there is any clerical discrepancy, and to notify the blood bank and lab. Next. So to summarize, any transfusion reaction happen after blood transfusion, you have to check the patient ID, take a blood sample from the patient, a fresh and new sample, and send it to the lab. The remaining blood should be put back to the blood bank also. The transfusion reaction investigation based on the physician request. And most importantly, you have to report this incident to the blood utilization committee. Next, this is I'm going to mention it briefly, the policies and procedure as per SIPAHI for blood transfusions. So this should be, the policy should be written by the blood utilization committee. Only physician should put the order for blood administration. The physician should obtain a consent for the transfusion. These should include description of the transfusion process, identification of the risk and benefits of the transfusion, identification of alternative, including the consequences of refusing the treatment, giving the opportunity to ask questions, and giving the right to accept or refuse the transfusion. Next. It have to be two staff members to verify the patient's identity prior to two steps. One of them prior to the blood drawing for cross match, and the second step prior to the administration of the blood. Sometimes in direct emergency, if the blood component was not screened for the transfusion infectious diseases by the NAT testing, another consent should be taken from the family prior to the administration in case of severe emergency only. The blood is transfused according to the accepted transfusion practice from the recognized professional organizations. Policies and procedure guide administration of blood transfusion. Next. So patients receiving blood are closely monitored. Transfusion reactions are reported and analyzed for preventive and corrective actions. Side effects or complications are immediately reported to the medical staff and the blood bank, and the transfused unit is sent to the blood bank for further investigation, as we mentioned. Lastly, this is some of the questions that may be asked during the Sibahi visit. We all mentioned that previously. That's all. Thank you so much. Thank you, Dr. Adnan.
Thank you, Doctora. Thanks all for attending, and thanks for all the pediatric quality team and Dr. Yasser from quality department. So again, it's quality. It's not the job only of the quality team. It's quality. It's everyone's responsibility. So without doing all together, so we'll not be able to achieve what we need. Thank you very much. I'm very sorry because we take a long time, but it was the last chance, as I mentioned at the beginning, to give brief things about